This talk is going to be on degenerative disease of the spine, and we'll talk about the anatomy of the lumbar discs and pathology. Then a lot of it is going to be on the nomenclature of disc disease. We'll talk about facet disease, spinal stenosis, then move on to cervical disc herniation and spinal stenosis and thoracic disc herniation, and then a little bit on DISH and OPLL. So just to start off of anatomy, this is the lumbar spine. So the disc is composed of the nucleus pulposus in the center and the surrounding annulus fibrosus. The annulus has an inner and outer portion, which are somewhat different in consistency. The endplate has a cartilaginous component as well as the bony component. So there's a hyaline cartilage along the bony endplate. And just comparing anatomic section to MRI. If you look on the anatomic section, you can see the nucleus pulposus here. And when you look at the disc on MRI, the central portion of the disc is bright. So you have all this that's bright, but this is not all nucleus. So the nucleus is in here, but the inner part of the annulus signal kind of blends somewhat with the nucleus. The outer part of the annulus out here and out here is very dark, but the inner part of the annulus is somewhere blends somewhere between the outer annulus and the nucleus. Just a transverse image showing the nucleus in the center with the annulus fibrosus surrounding it. Okay, so let's talk about degenerative changes of the disc. And there are two main categories that people describe. One is called spondylosis deformans, and that's considered to be just a component of normal aging. So just as during normal aging, osteophytes develop at the margins of the disc and the insertions of the Sharpie fibers. On the other hand, intervertebral osteochondrosis is actual degeneration involving the nucleus, the annulus, and the endplate. So that's what we're going to be concerned about here. So what happens with disc degeneration early on? There's a loss of water in the disc, causing a decreased signal on T2-weighted images, as you can see here at the L5S1 disc. The disc space gets narrowed, vacuum phenomenon can develop, and you can develop reactive endplate changes. So the endplate changes can be divided into three types. First, type 1 is vascularized and edematous marrow. So type 1 endplate changes are dark on T1 and bright on T2 because these are edematous marrow. The important thing about the type 1 endplate changes, you need to distinguish that from discitis. So the patient on the left, degenerative type 1 endplate changes, the one on the right, discitis osteomyelitis. So the important differentiating features with infection, often the disc is bright on T2, whereas most of the degenerated discs are dark on T2, and even more important, the prevertebral soft tissues, we'll see edema and enhancement in the prevertebral soft tissues in patients with infection, but not with degenerative endplate changes. Type 2 degenerative endplate changes are fatty marrow, so these are going to be bright on T1. Also bright on T2. If you do fat suppressed T1 weighted images or T2 weighted images, they'll be dark, but in typical images, bright on T1, bright on T2 from fatty marrow. So these are usually not a diagnostic dilemma. And type 3 is sclerotic marrow, which would be dark on all sequences. But often we'll see a combination of type 1, type 2, and type 3. So it's not all one or the other. They're often combined together. So one of the earlier features of disc degeneration is development of annular fissures. So on the anatomic section, this is a annular fissure over here with the arrow. This is a fissure or tear within the annulus, and this can be associated with back pain, but this is often a precursor to other degenerative changes in the disc, such as the herniation. So annular fissures are hyperintense on T2, so we can see one here, hyperintense on T2. Here it is on the axial image, and they often enhance with contrast. So disc herniation is when disc material passes through a fissure in the annulus and extends beyond the limits of the disc space. So you can see in the diagram normal disc, annular fissure, where there's a fissure in the annulus, but the disc material has not extended beyond the disc space, and then a herniated disc when the disc extends out beyond the disc space. So the herniated disc can include portions of the nucleus, the annulus, cartilage, and bone. So you should avoid the old term HNP, herniated nucleus pulposus, because the herniated disc is often more than just the nucleus pulposus. So by definition, a disc herniation has to be localized, which means it has to stick out less than 90 degrees of the circumference of the disc. So if it sticks out more than 90 degrees, it wouldn't be we would call it not a herniation, but a bulge, which we'll talk about a little bit later. So the disc herniations can be divided into protrusions and extrusions. You don't have to do this. In fact, it's adds some additional difficulty that's not often necessary, but it is important to know the difference. And so by definition, a protrusion means the widest part of the disc herniation in both the sagittal and axial planes is contiguous with the base of the parent disc, whereas an extrusion, the widest part is away from the base. And I will say this is often, these are often misclassified, and that's why I usually just use the term disc herniation. But if you look at the diagram, the one on the left here, this is a disc protrusion. The base of the herniation, which is here, is fully contiguous with the parent disc. This next one is an extrusion, so the widest part, which would be from here to here, okay, the widest part is not contiguous with the disc, so the widest part is out here, the disc is over here. And what's often confused is that this one is also an extrusion because the widest part of it goes beyond the confines of the disc. So if it sticks up and above and below the disc on the sagittal, then by definition it's an extrusion, even though on the axial image it may look like a protrusion. If it goes above and below on the sagittal, it would still be an extrusion by definition. Okay, when you describe a herniated disc, you need to describe the zone that's involved. So herniated disc can involve the central zone, which would be over here. Then the subarticular zone, which would be the next one out here. This is also the lateral recess. So lateral recess and subarticular zone are the same. That's between the medial edge of the facet joint and the pedicle. So it's called subarticular because it's deep to the facet joint, so subarticular. Then the foraminal zone, which would be between the medial and lateral margins of the pedicle, and the extra-foraminal zone would be lateral to the pedicle. So usually when you name them, you take where the center of the herniation is, and that's the zone that you would use. So, and it's also possible for the herniation to involve more than one zone. Okay, so let's look at some examples. This is in the central zone. So the one on the left is a central disc herniation. The one on the right also involves the central zone, but it's centered a little bit to the right of midline, so we'd call this a right central disc herniation. You can also use the term right paracentral, but right central is shorter, so I prefer that. Subarticular zone or lateral recess. So here's our herniation in the left subarticular zone or lateral recess. So these often will compress the nerve root after it's exited the thecal sac. So the nerve root has left the thecal sac here, and it's in the lateral recess and not yet reached the neural foramen. So subarticular herniation will often compress the nerve root in this location. And then foraminal and extra-foraminal. So this one on the left is centered to the neural foramen. The one on the right is centered lateral to the neural foramen. They both can compress the nerve roots, so foraminal and extra-foraminal. So disc material can migrate either up or down from its original location. This is what we call disc migration. If you look on the diagram, in the midline, the posterior longitudinal ligament is firmly attached to the vertebral body. So when discs migrate above and below, they don't do that in the midline. Off the midline, the posterior longitudinal ligament is not tightly attached to the vertebral body. So when discs herniate, it's usually either to the right or to the left of midline, and they can go up or down with relatively equal frequencies. Just an example here of a disc herniation with inferior migration, and again, it's not exactly in the midline, it's paramidline. So we can see in the midline, the disc just sticks out a little bit, and then once you get off to one side, you can see the migrated fragment. When a migrated disc fragment loses its attachment to the parent disc, we call that a sequestrated or sequestered or free fragment. Any of those words are fine. So that's a disc extrusion with migration where the migrated fragment has lost continuity with the parent disc. And here's just an example of a disc herniation with a fragment that's inferiorly migrated, and you can see on the post-contrast image enhancement all around this fragment because it's lost continuity with the parent disc, and we see enhancement all around it. So a sequestrated fragment. This transverse image showing this sequestrated disc fragment, and typically these will enhance at the periphery. So disc herniations will enhance along the periphery. That's another way to distinguish that from tumors, which usually will have more homogeneous enhancement. In the postoperative setting, it's sometimes difficult to distinguish epidural scar tissue from recurrent disc herniation because they can have similar signal on T1 and T2 weighted images. So these are two different patients. T2 weighted image. So we can see this disc at L4-5 and this disc at L5-S1. So one of these is a recurrent disc herniation, and one of them is epidural scar tissue. And a little bit hard to tell here. In the cases where it's hard to tell, contrast can help. So the disc enhances only at the periphery. So this is a recurrent disc herniation at L4-5. And we can see on the axial images, the enhancement just at the periphery of the disc, and the central portion of the herniation does not enhance with contrast. And compare that to this patient with epidural scar tissue at L5-S1. So here the whole thing enhances homogeneously with contrast. Also note the nerve root is surrounded by enhancement but not displaced. So typically the scar tissue will not displace the nerve roots. Just a couple of special cases of disc herniation. Intravertebral disc herniation, or Schmorl's node, is herniation of disc material through the vertebral end plate. These are very common. Most of the time they're asymptomatic, but they can cause back pain in the acute setting. You may see adjacent edema and enhancement with these Schmorl's nodes. And finally, Limbus Vertebra is herniation of disc material through the ring apophysis prior to fusion. So now let's move on to bulging discs. We use the term bulge if there's greater than 90 degrees of extension of disc material beyond the edges of the disc space. So disc bulges can be symmetrical or asymmetrical. The asymmetrical bulges are typically seen in patients with scoliosis. Facet joints, we'll first look at the anatomy. The facet joint is a synovial joint, so it's prone to osteoarthritis. The facet joints, however, have no anterior joint capsule, so the facet joints are bound only by the ligamentum flavum. So the ligamentum flavum forms the anterior joint capsule. Facet osteoarthritis is very common. We see bony overgrowth of the facet joints, thickening of the ligamentum flavum. You may see fusions in the facet joints, and facet osteoarthritis can cause spondylolisthesis and can contribute to spinal stenosis. So here's a patient with facet osteoarthritis here. A little bit of fluid, bony overgrowth, a little bit of spondylolisthesis. There's also a T2 hyperintense mass adjacent to the facet joint that's narrowing the spinal canal, and this represents a synovial cyst. So synovial cysts are usually related to facet osteoarthritis. You may see peripheral calcification in them. They can contain blood, and they can contribute to spinal stenosis. Facet osteoarthritis can cause spondylolisthesis, so we would call this degenerative spondylolisthesis, and this contributes to central canal stenosis. The other type of spondylolisthesis is called Isthmic Spondylolisthesis. This is secondary to spondylolysis, or stress fracture of the pars interarticularis. This usually occurs during adolescence, often related to sports. The degree of spondylolisthesis can be graded to 1 to 4, depending on how much slippage there is. If it's more than 25% slippage, almost always that's associated with pars defects. So the degenerative spondylolisthesis is almost always a grade 1. The isthmic spondylolisthesis often will cause foraminal stenosis, as we can see in this patient here. It does not cause central canal stenosis because the central canal is actually widened, caused by the vertebral slippage. Here's an axial image showing the bilateral pars defects. Often it's a little bit hard to see on the axial image, but one finding that's helpful is the central canal is widened from front to back in these patients. Spinal stenosis occurs when there's not enough room for the neural tissue. This can be caused by bulging disc and bony ridges, facet hypertrophy, spondylolisthesis, and congenitally small canal. So often there are multiple factors that come together to cause spinal stenosis. In the lumbar spine, we divide spinal stenosis into central canal stenosis, lateral recess stenosis, and foraminal stenosis. So first, central canal stenosis, where the central portion of the spinal canal is too small. So here's a case with relatively mild central canal stenosis. Another patient with more pronounced central canal stenosis here. Lateral recess stenosis is stenosis involving the subarticular zones or lateral recesses. So the areas deep to the facet joints of the lateral recesses. And one point that I want to make is the lateral recess is only a feature of the lumbar spine. So the cervical and thoracic spine do not actually have a lateral recess. So when we talk about lateral recess stenosis, that's just the lumbar spine. So this is a patient with mild lateral recess stenosis. And this is one with more pronounced lateral recess stenosis, where you can see compression of the nerves in the lateral recesses after they've just exited from the thecal sac. And finally, foraminal stenosis, stenosis in the neural foramen. And the foraminal stenosis is often better seen on the sagittal image, where you can see the nerve in the foramen being compressed here in a patient with foraminal stenosis. Let's move on to the cervical spine. There are a couple of differences. First, bony ridging is much more common in the cervical spine than in the lumbar spine. So often in the cervical spine, in addition to the disc herniations, you often see bony ridges covering the disc. So often we'll use the term disc osteophyte complex to imply the combination of disc material with overlying bony ridge formation. The cervical spine, we also have these uncovertebral joints. So the uncovertebral joints are prone to osteoarthritis. So as we can see here, there's a big spur arising from the left uncovertebral joint, and these uncovertebral joint spurs generally cause foraminal stenosis, as we can see in this case. So uncovertebral joints only are present in the cervical spine. The other thing about the uncovertebral joints is that they prevent disc material from herniating directly into the neural foramen. So see, you can see you have uncovertebral joint over here. That's going to block disc material from going directly out into the neural foramen. So if you see here's the disc here, and disc material can't herniate directly lateral because it comes up against this uncovertebral joint, because of the Uncinate process here. So that will prevent disc material from going directly into the foramen the way it does in the lumbar spine. So here's a patient with herniated disc in the cervical spine. Of course, there's a spinal cord that can be compressed. Here we can see disc material that's blocking the neural foramen, but it does not go directly into the neural foramen. It can't go through this uncovertebral joint. The disc comes out more posteriorly, and it could go into the foramen that way. So cervical disc herniation can cause radiculopathy or myelopathy, and the radiculopathy is most commonly occurs when the herniation occludes or nearly occludes the neural foramen, as you can see in this patient here. Spinal stenosis in the cervical spine can be associated with the myelopathy. So the cord can become injured due to prolonged compression. We often will see high signal within the spinal cord in these cases, like you can see here, so high T2 signal within the spinal cord. Most of the time this represents gliosis. Some of it can be edema, which is reversible, but often the majority of what we see that's T2 bright is irreversible cord injury. Occasionally you can have enhancement in the spinal cord at the site of stenosis, and this can mimic transverse myelitis. Thoracic disc herniations. One important thing about the thoracic disc herniations is that first, the patients will typically present with myelopathy rather than radiculopathy, and because the spinal cord is closely positioned, it's close to the vertebral bodies, you can have a relatively small disc herniation that can produce myelopathy. So even if you have enough fluid behind the cord, like you can see here, there's still fluid behind the cord, disc herniation can cause significant cord compression and can cause myelopathy because the cord is fairly closely applied to the posterior margin of the vertebral bodies because of the thoracic kyphosis. So here is a patient with a thoracic disc herniation. You can see it indenting the spinal cord. Another patient with a thoracic disc herniation here, and it's not a big herniation, but yet there's a significant amount of T2 signal within the cord in this patient with myelopathy due to thoracic disc herniation. Finally, we'll talk about what we see here. So, extensive ossification along the anterior longitudinal ligament, fairly thick. This is a patient with DISH, diffuse idiopathic skeletal hyperostosis. Contrast that with ankylosing spondylitis, where you have relatively thin syndesmophytes fusing the spine. Both the DISH and ankylosing spondylitis, you have a rigid spine that's more prone to fracture. So you can see here a fracture with a patient with DISH. These fractures in DISH or ankylosing spondylitis are often associated with a neurologic deficit. This patient with ankylosing spondylitis and a fracture here. You can see the fracture goes all the way through the posterior elements because you have the whole thing is fused together, and often associated with neurologic compromise. And finally, this is a patient who has spinal stenosis due to this big calcified lesion coming out of the center of the vertebral bodies. This is a patient with OPLL, ossification of the posterior longitudinal ligament. Often it has this mushroom-shaped configuration, and it's typically more pronounced at the vertebral body level rather than at the disc level. So that way you can distinguish it from, say, just calcified disc herniation. So this is OPLL and often causes spinal stenosis. So let's just do a quick review. So disc herniation has to be focal, less than 90 degrees. If the disc sticks out more than 90 degrees, we call it a disc bulge, either symmetric or asymmetric. The asymmetric bulge is more common in patients with spinal stenosis, with scoliosis. Disc herniation can migrate, so this example shows downward migration. The migration is usually either to the right or to the left of midline, and if the disc materials become separated from the parent disc, then we call it a sequestrated or free fragment. This shows the different zones of disc herniation. So first we have a right extra-foraminal disc herniation centered in the extra-foraminal zone, then a right foraminal disc herniation, a right subarticular disc herniation, and a right central disc herniation. In terms of postoperative disc versus scar, the contrast can be helpful. So postoperative disc herniation will enhance only around the periphery. Scar tissue, the whole thing enhances homogeneously. Spinal stenosis, we can divide into central canal stenosis, lateral recess stenosis, and foraminal stenosis. And remember, lateral recess stenosis only is a feature of the lumbar spine. Central canal stenosis and foraminal stenosis we can see in both cervical and thoracic. Synovial cysts associated with facet osteoarthritis often contribute to spinal stenosis. Spondylolisthesis can be degenerative, secondary to facet osteoarthritis, as in the case on the left, or it can be secondary to Parr's defect, which we would call Isthmic Spondylolisthesis. Remember, the degenerative spondylolisthesis causes central canal stenosis. The Isthmic Spondylolisthesis causes foraminal stenosis, but no central canal stenosis. In the cervical spine, we often will get myelopathy associated with spinal stenosis. We'll see some increased T2 signal within the spinal cord. And OPLL, look for that mushroom-shaped calcification, which tends to be most pronounced at the vertebral body level rather than the disc. Thanks for your attention.